Okay. Well, good evening all. Welcome to members of the Health and Adult Social Care Policy and Accountability Committee to this evening's hybrid meeting. And welcome also to officers, guest presenters, and observers. And in particular, I would also like to welcome colleagues and officers who join us via Zoom. I hope you can see us and hear us okay. Welcome all. I'm Councillor Natalia Perez, and I have the pleasure of chairing the first in-person meeting for 22-23. Before we begin, I have a few quick housekeeping notices for you, please. Please wait for me to prompt you before speaking. If you would like to speak, please indicate by raising your hand, tell us who you are and your organization, if any. For those of you joining us by Zoom, be assured that you will be fully included in the meeting. Shiva will be monitoring the screen, but please do let us know if we have missed your signals. We have officers, external guests, and observers here this evening, both in person and online. If invited to speak, please introduce yourself and tell us who you are, especially for the benefit of those here in person. Please help yourself to refreshments available here at the end of the table. And also keep yourself self-hydrated. If you need a comfort break, there are facilities located by the lifts. The nearest fire exits are also located near the lift. We are not expecting there to be a fire alarm test this evening, so please respond if the alarm is activated. As this is our first meeting, I would like to invite members and officers to please introduce themselves, beginning with our PAC members online, then members in attendance. Okay, can we please start with members online, please? Have we got Councillor Quigley with us?
Good evening, everyone. I'm Patricia Quigley, and I'm the lead member for Inclusive Community Engagement and Co-Production, and I'm very happy to be attending tonight.
Thank you very much, Councillor Quigley. Have we also got Victoria Brignall, please?
Hi, everyone. Yeah, I'm Victoria Brignall. I'm the current chair of Action and Disability until Monday. I'm looking forward to this meeting.
Okay, thank you very much. And here present with us, we've got... Oh yes, apologies. Have we got as well Jim Greeley?
Hello, Chair. I'm delighted to be at the meeting. I'm Jim Greeley from Havson, Save Our NHS, Hammersmith and Fulham. Delighted to take part.
Very nice. Thank you so much. I'm going to ask officers to please hold on us. You'll have an opportunity to introduce yourselves when you present your agenda items. I would now like to go back to members here present with us.
Hello, I'm Genevieve Warbett. I'm one of the new councillors and I'm a member of the Health PAC here, and I'm just really pleased to be a member of this PAC.
I'm Councillor Amanda Lloyd-Harris. I'm the opposition spokesman for Health and Adult Social Care, and this is my second term on this PAC, which I'm looking forward to. Thank you.
Keith Mallinson, co-optee, and this is my second term as well.
Well, welcome all. We also have with us Councillor Ben Coleman.
Yeah, I'm Ben Coleman. I'm Deputy Leader and I'm responsible for Health and Adult Social Care. And I'm here to be, as it were, probed by the PAC. Help the PAC.
Thank you very much. And we also have with us
Lisa Redfern, Strategic Director of Social Care.
Okay, well, thank you very much. Of course, and we have
Bathsheba Moore, Committee Coordinator for Health and Social Care PAC.
And thank you very much.
That's great.
Yes, what we want to do is ask officers and other NHS colleagues to introduce themselves when they present their agenda items, if that's okay, in the interest of time. Thank you. I would now like to take the opportunity to thank my predecessor, Councillor Lucy Richardson, for leading this committee so ably for 5 years, maintaining health scrutiny and accountability during this incredible challenging time. And as I'm sure those of you who worked with her would agree, Councillor Richardson led on a number of areas, including mental health and inclusive apprenticeships. She leaves the legacy of a collegiate approach while at the same time holding health services to account through rigorous and challenging scrutiny.
May I add something to that? And also, Councillor Richardson is going to be focusing, as the lead member for mental health, is going to be focusing very hard on improving the services for residents and outcomes for residents in that area now. So she's very much, and I hope she'll be coming back to the back at some point so she can talk about the work.
Absolutely, she's very welcome to join us again. Okay, well, thank you all. Let's move on then to agenda item number 1 of the agenda pack this evening, which are the minutes of the previous meeting. And please note that these have been approved by the outgoing chair, Councillor Richardson. It's for the minutes of the meeting held on Wednesday, the 23rd of March, 2022. I understand that there's some actions that you wanted to update.
Yes, absolutely, Chair. So there's still a number of actions outstanding from the last meeting, as you might be aware, from West London Trust, and they were appendix to the minutes of that meeting. So they're in the public domain for information for anyone who cares to see them. We are still continuing to monitor them, and we are trying to agree a way of feeding that back to the committee in due course. And there's some discussion later on in the meeting about how that will be handled by the committee as well. Councillor Perez has actually been briefed by officers, and we look forward to arranging a further meeting, which is almost confirmed for the 25th of July, with senior officers from West London Trust to follow up on this, and obviously to give her a breakdown of the work that they've been doing in the PAC, so she has an idea of what's gone before. We've done those briefings. So, sorry?
Can they hear?
Can I just check colleagues online can hear? Thank you. I think it's more of us. Yeah. There's just 1 or 2 other things, and there were a couple of actions outstanding from the last set of minutes, which we have followed up on, and I'm happy to follow up outside the meeting with any further information.
Okay, thank you. Thank you very much, Fatima. Are there any questions in relation to the minutes of the meeting held on the 23rd of March? And they have been agreed. Okay, thank you very much. Let's move on to agenda item number 2. Apologies for absence. So we had apology from Lucia Boddington. We've also had apology from Councillor Anne Rosenberg and also Roy Margolis. Okay. Agenda item number 3, declarations of interest. Are there any declarations of interest, please? And the colleagues joining us online.
Hi, I just want to Bathsheba note it, please. Item, I think it's number 6, the safeguarding adult pool, that I'm a former member of it. Please.
Sure,
I know it's not a declaration, but I think it needs to be noted.
Okay, thank you very much, Councillor Quickly. We've noted that then. Are there other declarations of interest? Okay, not from colleagues online and from colleagues here. Okay. Thank you. Okay, then agenda item number 4, public health update. This is a standing item for the Director of Public Health and the Director of COVID-19 Refugee Lead to provide an update about health issues and services affecting the borough and its residents. Understand that we've got the Director of Public Health, Nicola Lang, here with us.
Hi, Councillor Perez. Thank you, and thank you for inviting me. So the 2 main items I was going to speak to are monkeypox and also COVID. So in terms of monkeypox, you may have seen cases are rising. There are 1,735 cases in the UK, 1,660 in England, and 1,229 in London. So the gist of that is that the vast majority of cases are in the London area. In terms of the risk group remains the same. So that's men who identify as gay, bisexual, or men who have sex with men. It has brought us all together as a health system, together with the hospitals and also genitourinary medicine. We are doing a lot of work with hospitals on helping people who don't need to be there to safely discharge if they don't have a place that they can isolate. So that's been really positive, working together with housing. Other good things that have been possible were around a worry that there would be displaced activity around family planning. So because our sexual health clinics have been so busy doing monkeypox, we had concerns in the system that there wouldn't be enough capacity to do family planning. But again, that's yielded a good result. And we've had a good offer from the John Hunter Clinic at Chelsea and Westminster that we can send women there if they weren't able to come to 10 Hammersmith Broadway. The other good news story that you may have seen in the news is that smallpox vaccine is now coming out in big tranches to help vaccinate this at-risk community. And it's been very, very positively received. So that's a wonderful thing. In terms of COVID, we have, you will see that cases are rising across the whole country. And in terms of locally, we have a number of outbreaks in our nursing homes and care settings, but fortunately, because pretty much everyone is vaccinated, most of our cases are actually completely asymptomatic or just have very, very mild symptoms. And fortunately, so far, no one's become seriously ill or gone to hospital. And again, that's thanks to the vaccine. So a number of outbreaks and cases rising, but so far things have been okay. Thank you very much.
Thank you very much, Dr. Lang, for the update. Have we got any questions from members online? Councillor Quigley?
Sorry, yeah, sorry. I keep forgetting to put up my computer hand, I'm so sorry. Thank you for the update, Nikki. Are we putting out enough PR to warn people, men especially, about the monkeypox? Because I've been seeing enough stuff online, so it's I'm just wondering, are we putting out stuff out there to kind of advise symptoms and things like that?
Good question, Councillor Quigley. There's been a lot of communications done through specialist channels. So Terence Higgins Trust, which is a support group, nationally known charity, has been leading on a lot of the communications. But we're lucky that locally we commission a service. It's called SASH for short, but it's a sexual health outreach service. And it's a mini consortium between NAS, Metro, and a few other charities for gay men. They've been working to really get under the skin and really work locally with people who may be at risk. And we've also reached out to our one venue, which is a gay bar called Ted's in Fulham. So we have reached out from our genitourinary medicine service. They have their databases, and they've done all that sensitive and appropriate kind of outreach many, many times. The exciting thing now is come and get vaccinated. So, and again, that's being led by those groups. But it's been very satisfying and rewarding to actually start work with those community groups.
Yeah.
And they actually started doing some face-to-face work as well, which is really exciting.
Yeah, it sounds good and positive, and maybe because of the experience we had with COVID and working with other groups, this is something that we can carry forward, because as I said, I'm just concerned that communities might be left out. So thank you, Nikki, for the update.
Thank you.
Okay, I also see Victoria Brignall as well. You've got your hand up, Victoria.
Thank you, Nikki, for your report. Obviously, the other public health issue we're facing at the moment is the extreme heat wave. I wonder if my fellow committee members agree whether at the next PAC meeting, whether you could give us an update on how that's affected this borough and what responses that the council and other organisations have made to try to mitigate the effects of that, and what steps you've taken to try and deal with it in the future.
Yeah, thanks, Victoria. That is a really good question. And with Chair's permission, I think it would be good to invite the emergency planning team. I think what this heat wave has thrown into stark relief is how do we prepare ourselves better for being a very hot country, so it's not just putting the warnings out. It's how do we actually put a protectiveness around settings with vulnerable people. So care homes, schools, people most vulnerable to the heat. So older folks and younger children. How do we make buildings heat secure? How do we use things like awning, white paint, reflective surfaces, using recycled materials that don't retain the heat? So I'm just about to start a big piece of work with the Environment Department on the future, because you're right, Victoria, there's the now and there's, oh, it's going to be very hot. What we need to do as a country, but then also as a borough, is with climate change, you know, getting really prepared for it, is how are we ready so that when we get this next terrible heat wave, we can say, actually, our buildings, roads, infrastructure, places where vulnerable people are fully prepared, and we just note the heat. That's where I would like us to get to. And it's super, super important. So yeah, definitely, let's do that.
Okay, thank you very much. I see Jim as well. Jim, really, you put your hand up as well.
Yes, indeed. First of all, I wasn't going to say this, but Nikki was very heartening about preparing us for a probable next heat wave. And we're quite clearly not a well-prepared country because we simply aren't prepared. But the fact the borough is actually thinking ahead like that, I think will make us feel much more conscious about what we need to do as residents, citizens, and as a council for other climate change events, which may well be extreme cold, rain, or heat. And we can't predict exactly, but we do know that things are not going to go back to being comfortable. I was going to ask a different question, though. It's on COVID and vaccination. The vaccination program started very slowly, and then, thanks to the council, in great part working with the local NHS, sped up a great deal. Now, the government is planning to roll out an additional booster sometime in the autumn for the over 50s. And I'm wondering whether Nikki and her team are getting together with the local NHS and perhaps the hospital trusts to model how the over 50s can be induced to come out, to make certain that they get a booster when it comes online sometime in mid-autumn.
Thanks, Jim. I'm wondering if I can pass that over to an NHS colleague, because we've seen the new categories. So as you say, over 50, people who are susceptible and at risk. I don't know if, Philippa, you're able to take that to describe where it's going in primary care and how it's going to be rolled out.
I'll take it, Philippa, if you like.
Oh, thank you, Sue. I was going to suggest that. Thank you.
Welcome to.
Oh, yeah. So yeah,
introduce yourself as well.
So I'm Sue Rooston. I'm the Borough Director for Hammersmith and Fulham, so responsible for the vaccination programme locally. Yes, you're right, Jim. They have made the announcement that it will be cohorts 1 to 9, so booster programme in the autumn for anybody eligible over the age of 50. We have started the preparation work in terms of planning, i.e. what number of residents and registered patients does that mean for us in Hammersmith and Fulham? And we are also assessing the capacity that we've currently got, both from our primary care colleagues, our hospital sites and our community pharmacies. We imagine that most of it will be undertaken through community pharmacy routes with support from primary care colleagues. And obviously we will be focusing on our housebound patients, our care home patients and the vulnerable cohorts that we have done previously as well. It's difficult to say at the moment when it will exactly start, because obviously there's still waiting for the vaccine and when that will come in, and again whether or not we can dovetail it with the flu programme, because as you know, obviously trying to sort of administer that together is also sort of positive and beneficial. So that's probably all I've got to say at the moment on it, but obviously happy to update. And yes, Nikki, we can look forward to probably having weekly meetings again. That joy that we had for the past 18 months will carry on come September. So yeah, we'll set that up again. That help.
Thank you so much. Very helpful. Yes.
Can I just that's really helpful, Sue. Can I just ask a question? What was really good about the way in which everyone came together to tackle the pandemic, the first round of vaccinations, was how in the end and you've mentioned it, we've got lots of pharmacies to become the hub, the places where people went to get their vaccines. And I think in the end, we ended up with, you'll remember better than I did, 10 or 12, 10. Do you know if it's going to be, I mean, the more, we've always said the more the better, because that's what really works. Do you think, is it going to be 10 pharmacies again, or do you think we might actually have more? We've got loads and loads, dozens in the borough. Might we get more?
I think it'll probably stick with the 10 because it was offered around. So there will be opportunities for other pharmacies to come in, but the assurance process is quite significant to get them assured and sort of on the books, as it were. We've got sufficient capacity. So when in the height of the COVID vaccines previously, we had about 9,000 appointments, 9,000 vaccines available through community pharmacies. We're probably looking at a cohort of about 100,000 to take us down to the over 50s. And I think we've probably got sufficient capacity with what we've got currently. And they are quite geographically spread. So I think we'll probably be okay. But if pharmacies come forward and they want to go through that process, then they will have to go through that with NHS England. Yeah.
And have they, that's really helpful. And do the pharmacies, can we approach the pharmacies through the pharmacy committee?
So we have contacts with the LPC. So yeah,
and tell them that they can come forward if they didn't come forward last time, that they'd have to be assessed and they'd have to meet these requirements.
So what we would need to do is double check with NHS England that they are going through that assessment process. So if that is available, then obviously we can approach through the LPC.
But let them, I just meant let them know in the first place that the opportunity is there.
Well, we need to check.
We need to check.
Is there.
That's what I was trying to get to. So can we have more than the 10?
So we haven't had that information yet. The information from the JCVI was only announced less than a week ago. So the information is still feeding through. So I think what Sue was saying is once we get the information about what the process is and whether or not there is a further application process for pharmacies, then we will obviously communicate and let the local system know that as well. But I think it would be presumptuous at this point in time to do that, because it might raise an expectation both for the community and for the pharmacies until we've got that.
I think we just lost them.
Yeah, it should come back in a second.
Yes.
I wasn't sure if it was mine that had frozen or if
No,
it was
I
them.
wasn't sure if it was mine either.
No, I thought something had happened in this part of the world.
We're all looking at each other there.
It's good that we're together.
I was going to say, how ironic that the ones online are fine and the ones that are not are not.
Shall we go on with the agenda?
Should we start singing or something?
Are colleagues online okay? Is the connection okay?
It's returned now.
Or you lost it for a little bit?
Yes.
So yes, we were saying that our next our next meeting will be on the 16th of November. So hopefully we'll have an update on the rollout of the vaccination. Okay, I want to ask colleagues here present, please, if you've got questions for Nikki or for Sue, please. Yes, Councillor Lloyd Harris.
Oh, that would be me. Thank you. Okay, just a couple of things. Now, Dr. Lang, I'm not sure if I misheard something, but when you were talking about the monkeypox, that I believe we got 90 cases in the borough, but then you went on to something about smallpox. And the vaccination for that? Are we talking about two separate things here, or are they linked?
Yeah, they're linked. So the smallpox vaccine, and it's not like the old-fashioned smallpox vaccine, it is a safer, different version of it. But yes, you are right. The smallpox vaccine confers a degree of protection against monkeypox. They're in the same family, and nobody knows yet the exact level of protection, but it's thought to reduce the severity of disease, which is wonderful. So this is a good thing that's happening.
It's using the
Smallpox vaccine. Okay, and just one other quick question is that previously we had the rollout of the COVID vaccines, which was pretty effective here, to be honest. We had mobile bus available. Is that going to be part of the program going forward?
No, it wouldn't be, because the at-risk group is a sensitive group, and we do not wish for people to have to identify themselves publicly. So all the vaccine delivery is being confidentially and quietly done by sexual health clinics where men feel safe.
Oh, sorry.
protected,
I think we're
and-
talking
oh,
cross purposes.
oh,
Apologies.
sorry.
I meant, sorry, it was me that jumped. About the COVID vaccine, when we have the booster coming up, I'm not suggesting people, it'd be like sort of going around if you had HIV and saying, please come out to a bus, no
Oh.
emergency. I mean, that would be absolutely appalling. I'm not talking about that, I'm talking about the COVID.
Okay.
Because if we get 50,
Yeah.
there's obviously, as we've said, a lot of the community will be hopefully lining up for the fourth vaccination. So will we be using a mobile service as well?
Could I pass that one back to Sue again? Sorry, just as the vaccine lead.
Lots.
Because we've got sufficient capacity in the system. Obviously, if they're elderly and vulnerable or care home or housebound, then we will be doing domiciliary visits. So we will sort of make those visits. But the others are sort of generally the expectation would be that they either go to their practice, you know, to a sort of a PCN hub or the community pharmacy.
Thanks very much.
Okay, thank you very much. Keith, do you have a
No,
question?
no, just under.
Okay, are there any further questions or comments? Okay, well, thank you so much, Nikki, and thank you very much, Sue. Before we move on to the next item, can I would please note which are the actions that you're putting up?
Chair, we have 3 actions. We have an item on how the heat wave has affected the borough and what's been done to mitigate and the steps to be taken in the future, and the work that Nikki's doing with the Environment Department on that. There's an offer to invite the emergency planning team to discuss how we prepare ourselves better to deal with this in the future. Sorry, I'll try and speak up. And then on that last item, another action around COVID and updating the PAC in the autumn.
Brilliant. Thank you very much. Okay, thank you all. So let's move on to the next agenda item, number 5. The NWLICS update on community-based specialist palliative care services improvement program. So, excellent, great. Okay, and we also have colleagues presenting online. Okay, well, thank you very much, and welcome to colleagues as well for joining us through Zoom. Could you also please introduce yourselves?
So shall I start off? I'm Robin Doran. I'm the SRO for this programme for North West London. My day job is I'm the ICP Executive Director for Brent. I work for CNWL NHS Trust. I'm a nurse by background, and I have lived experience of caring for both my sister and my father who died at home.
Welcome, Robin. Okay, do we have other colleagues online?
You've got Philippa.
Philippa Johnson.
Yeah, hi, I'm Philippa Johnson. I'm the director of the borough-based partnership for Hammersmith and Fulham. I also work in Central London Community Healthcare Trust. I'm a pharmacist by background. Also.
We've got 2 in the room. You'll never have enough.
No.
Thank you very much.
And you've got Michelle.
Hi, I'm Michelle Scafe. I'm the Programme Delivery Manager for the Last Phase of Life programme, so supporting with the delivery and transformation work around this programme of work. And I'm actually an OT by background that used to work in RBKC.
We've got Chaksi.
Hello everyone, thank you for inviting us. My name is Chakshu Sharma. I'm Programme Manager, Integration and Delivery, work in Hammersmith and Fulham Borough team in North West London, NHS North West London now. And I'm supporting the end-of-life engagement process from the borough side.
And then we've got Andrew as well.
Yeah, I'm Andrew Pike. I'm the communications lead from NHS North West London, the ICS for this programme. I don't have a background.
He's not going to want to, he's not going to admit to it. And we also have, so we have Meryl and Jim that are also part of the engagement process, but they're obviously not going to be presenting, but it's important to say that they've been part of the local engagement process.
Well, thank you very much and welcome all. So over to you.
Okay, so I'm just going to introduce this, and then obviously the team on the screen will probably be the main focal point to answer the questions, and I'm going to hand to Robin to also give a bit more info about the programme. But firstly, thanks for inviting us today. The North West London ICS wants to work with the local authority in Hammersmith and Fulham, patient, carers and families and other stakeholders to understand how we can improve the experience for all adults who are using community specialist palliative care services. There's a North West London-wide steering group that's been established, and it consists of NHS providers, hospices, local authority and resident representatives. And there was an issues paper published last November, which obviously sets out the key reasons why we're looking at this service, and obviously hopefully helping us having the conversation on what the future might look like. So our engagement from a Hammersmith and Fulham perspective started at a North West London level on the 18th of November last year, and continues as we go through this. And we've set out and published an interim engagement outcome report that sets out the feedback that we've already received. Locally in Hammersmith and Fulham, the Health and Care Partnership has set out a strong commitment to co-production. And we are mirroring that approach that has been adopted by the local authority already in a number of areas, but also enhancing that with the Health and Care Partnership, the learning that we're taking. So we've started to engage with our residents and communities right from the very start so that we can understand what matters to them and how we can work with them to make changes. So through CHACSU, as part of our borough team, we've worked really closely with lay partners and members of HAFSON to design our engagement material, agree the narrative and host rich conversations promoting our engagement event as well. We've had listening events that have been very well attended and productive, and obviously the content is in the paper. Locally, it's been agreed for us to extend the scope of the engagement so that we really cover the breadth of out-of-hospital palliative care. We heard loud and clear that the community specialist is one part of it, but actually people wanted to talk about palliative care services in their entirety. And then obviously any feedback that we have will be passed back into service development as at the North West London level and locally. And HAFSON have also provided a welcome submission to the North West London programme, and obviously all of our local work will be fed in to that too. So I'm going to pass to Robin, who's going to talk about the model of care working group, and then obviously open it up for questions.
Thank you, Sue. So we have, as Sue said, an overall steering group that has a number of stakeholders that's overseeing the whole process. But more recently, we developed a model of care working group across North West London that's currently meeting on a weekly basis. It's developing a framework and an action plan to ensure that high quality community-based specialist palliative care is delivered equitably and sustainably across the whole of North West London, and that all residents across North West London are able to access the service if it's needed. As Sue said, the feedback from your local sessions and the work that you're doing in HAFSON is feeding into that, as are all the other boroughs who are going through a similar process. Membership of the group that meets weekly is inclusive of local residents, some from Hammersmith and Fulham, clinicians, other palliative and end-of-life care stakeholders, patient and carer members, contribute and provide feedback on the group's work, which reflects the voice of residents, patients, carers and their families. Our expectation is of an ongoing resident and stakeholder involvement of this. We're very aware of a number of groups from different communities, from protected characteristics, that in the past haven't always been represented in North West London processes in terms of such an in-depth review. So what we're making sure of is that you are leading this locally. So in the same way that Hammersmith and Fulham has very much got an in-depth stakeholder process, in Brent, the borough that I'm the ICP director for, we are also having an in-depth process. So at local level, as well as at North West London level, we're making sure we're hearing the voices of people. And actually those people are shaping what the model of care is, including the experts from the stakeholders, such as the providers who are delivering sessions. So I'm going to hand back to you.
Thank you. So obviously we've submitted a number of papers, and obviously it's got quite a lot of feedback in it. So I guess it's over to the panel for questions, and I think they will be mainly fielded by the North West London team that are on the screen. But obviously from a local perspective, Chaksu and Jim and Meryl may want to comment on some of the work that we've been doing locally as well.
Thank you very much, Sue and Robin. But before we move on to questions, I wanted to apologize to
fine.
Janet because we didn't have a chance to introduce yourself. So
That's fine. Yes, very brief. I didn't want to say yes. So Chief Operating Officer for NHS North West London with responsibility for Hammersmith and Fulham as part of that remit.
And a background as a
Pharmacist.
Just sorry, I thought that. Anyone else? It's just the two.
okay, thank you very much. So yes, Keith, you've got a question.
Yes, I have. Unfortunately, sadly, my partner died 2 years ago. And he was in Royal Trinity. They did a fantastic job, and I liked it recorded at the work they do because it's unstinting. Nothing was too much trouble for them. Before he went into the hospice, the district nurses came round, or community nurses came round. Now, they were in the main good, but occasionally they missed a visit because maybe shortage of staff. So that is probably an area which needs to be looked at for patients who are receiving help at home, that it needs that continuity of care rather than, oh, we can't come today. So yeah, that's basically, but I would like it noted about Royal Trinity.
Yeah. Thank you. We'll note the other comments as well.
Thank you very much. Councillor Harris.
It's one I've raised a number of times before, but I'll have another go at it. Because in the report we talk about Pembridge Palliative Care Centre. We keep talking about it. We don't seem to get very far on it. We've now had 4 years when this service has been suspended. Now, we keep saying there's an issue with recruitment. 4 years on, we still can't recruit someone. I find that quite disturbing. And I'm just wondering whether that, to be honest, is used as a reason not to be spending more money by bringing it back for patients, or in fact, it's more that, we're just not working hard enough at it, because it's the same excuses for 4 years, it doesn't change. And I'm just wondering whether there really is any intention of bringing it back for those that actually would prefer to be going to, if they would prefer to be going to a hospice, obviously, clearly not. But something is close by so their family can actually visit them, because there's nothing worse than going out of borough to go and visit, dying family and friends. I did it with my father for 18 months and has got nothing to recommend it at all. I'm just wondering if we get some sort of update that actually really does suggest something is being looked at.
So I'm going to look to my North West London team, or Philippa, I think, may want to come in on this with a.
Yeah, I should probably handle that. So I'm responsible as a provider for the Pembridge service. So just to make that really clear, so Central London Community Healthcare. It is really, really challenging. I totally understand the perspective. It is a long time to be really struggling, but there is a national shortage of specialist palliative care consultants, and there have been several attempts from 2018 to recruit into the post, and I think the journey of trying to recruit or work with partners to see whether we can utilise the very scarce resource of consultant specialist palliative care consultants across the wider system partners, is something that we've been actively on throughout that time. So our latest attempt was really between March and May 2021, working with Imperial and St John's Hospice, really to look at, because we had vacancies both in Imperial and at St John's Hospice. So looking at whether we could put something in place to recruit something that was attractive to a wider people, so that you've kind of got that balance of an acute trust plus a community provider. And we tried to work something up over quite a challenging time period. But actually there was just not, we couldn't get to a position where we could put something in place that didn't destabilize another part of the system. So we didn't pull that off. So we've tried lots of different things. It is really challenging. And obviously part of that picture is, whilst there is a review on, it would be really difficult to attract a consultant resource. So I think really important that we crack on with the model of care and the workforce model to go with that, so that we can secure both the model and the resource that we need to deliver that. And I hope that makes sense.
Yeah, I think it might have been easier just to say that we haven't got any further. That's pretty much what you
said. I think saying we haven't got any further kind of indicates there's a lack of trying, and that is definitely not the case.
I don't think anything to say you haven't tried. I just feel that maybe we're not being quite as creative as one would like to see. But if this is where we are, this is where we are. So
it is where we are, yeah.
Obviously.
I think the other thing to add just about finances, which is the other point that you made, this is not about saving money. This is actually about trying to work within the resource we've got. So we're not actually this process is not going through a process to try and cut costs and save money. That's not the essence of what we're trying to do. This is about improving the offer across the whole of North West London so that people get the best experience for them and their family.
And if I could just add to that, it was just to say that the funding, specifically from a Pembrokeshire perspective, has been ring-fenced and has all been reinvested back into the community-based specialist palliative care. So it isn't about, because I think you mentioned saving money within that, and that absolutely isn't the case. And the specifics around from a Pembrokeshire perspective are also remain as they were, and we gave that assurance at the time, and that remains the case.
It's helpful to know it's still in place. So thanks.
Well, thank you very much, Philippa.
Sorry, can I just add as well? Sorry, I had actually put my hand up before. So firstly, to Keith's point, just to say thank you for sharing about Royal Trinity, and I will gladly pass that information back to them. I think they'll be really, pleased to hear that. But also just to add, there is also a North West London review of community district nursing that has taken place or currently happening, where they have looked at a common core offer and getting this hospice, the community teams to sign up to that for delivery. And part of that is improvements around competencies for end of life care coordination. And part of the work that we're then doing with the review is absolutely recognising the integration with those services and that improvement work that's happening. So just to give you those assurances that there is work in the wider palliative care space happening through district nursing, and that this work is absolutely not taking place in isolation. And then going back to the Pembridge point, just to add to what others have said, the review is absolutely recognising that the local residents would like something of that nature and services local to them. And that is definitely being heard loud and clear and factored into any of the work that we're doing. And we are overtly, mentioning that in our engagement report, and we are bringing it into the space during the model of care working group meetings to try and look at what that means for the local residents who are, as you mentioned, having to travel to other hospices. So we recognise that, and that it's not off the table, but we do need to consider, as you say, other options around how we can get the right workforce to support that service, or something of the likes going forward that's local to people.
Thank you, Michelle, for your contribution and further information. Okay, I Councillor Quigley, and then Jim as well. Councillor Quigley, over to you, please.
Thank you. Thanks for doing the report. Sorry, I'm going to be really picky here now. So I've spotted a typo on page 22. It's the date, the 18th of November, 2022. So you might want to correct that.
Sue corrected that when she was talking. Yeah.
Right. Okay. Good. That thing picked up. I was reading the report and I was really interested about on page 42, empower family and carers to handle meds. I have a lived experience of caring for both my parents. My mum had cancer and my dad had a stroke, and I actually cared for my mum at home. And I think it's a really good idea if carers, and especially families, could be empowered in some way to care for their loved ones. Because I did it for my mum, and it gave me a sense of being there for her at the end. I mean, it is. I wouldn't suggest for 1 minute. It does say in the document about giving injections. I'm not sure I do that. I'm not sure my mum would have allowed me to come near her with an injection. But you know, but I think it's really. I think it's a good way to get loved ones to care for at the end, because when you're left behind and you have to live with the pain and grief, and you know you've done the best, you know, I just think it's something that might be worth putting some thought into. My dad spent 6 weeks in Charing Cross Hospital. There'd be often days where the nurses would be so busy that I would want to do the caring for my dad, but I couldn't because he's in a hospital environment, so you can't do that. I had the opposite with my mum at home. So I just think it's I'd be really interested. I'd really like to hear more about empowering family, maybe minus the injection. So
I think your comments are common, Councillor Quigley, from other families as well, and certainly from my own personal experience. And as I am a nurse, I could give injections, so it kind of made it my parents, they're okay with that. But I think there is something, not all families do want to be able to do that. So it's a balance. It's about those families and those caring for their loved ones that want to be able to look after them, and people want to die at home, then we give them the right support for that. So we're very happy to follow up with you, and if you want to get involved in it in some way and share your experiences, then we're very happy to hear that, and thank you for sharing them today.
Thank you very much, Patricia, for sharing with us your experience as well with your mom and your dad, and some of those recommendations from that lived experience as well, and Robin as well. It's appreciated. We've got Jim, and then we've got Meryl, but I know that Michelle, is that a legacy hand, or is that?
I'm going to take it down because Robin has taken the words out of my mouth, but just to reiterate that this did come up in the model of care working group, and just to say that obviously it's, you know, we don't want to create a system where the family are the backstop for it. We want to create a system that allows people, exactly to your point, Councillor Quigley, that if they want to have that is an option, and that we do need to provide more support. And we do know that we've got some of that good work happening in Hillingdon, where they have been putting on training sessions for family members to support with medications, and that is something that we will definitely be looking at as part of our kind of competencies and training offer going forward with the model of care working group as well.
Thank you, Michelle. Jim.
Thank you. First of all, I've worked with Sue, with Czech Sue, with Philippa, and I must say, as a model of co-production and listening to each other, it was outstandingly good. It was the best piece of engagement I've ever been involved in as part of my campaigning in this borough. And I would like to say thank you for setting up so many sessions, for listening and learning from each other. It really was very useful. Some things strike me looking at the paper, looking at my notes from earlier meetings and looking from where we go. I think the thing which Amanda raised about staffing is very important. There's been an attempt to get somebody, and there's a recognized shortage of specialists in that field. But as those of us who go to board meetings of trusts know as well, there's a shortage of cancer specialists, a shortage of leukemia specialists, there's a shortage of emergency doctors. I could go right through it. So there's nothing unique about the shortage of people who work in hospitals as doctors. And I think that's quite important, because one of the themes which came up, I think, from both my own experience, and I have, both my parents died in hospital of cancer. They couldn't have been looked after at home. I helped look after a younger brother having to go to a different country. He died in hospital, and I didn't have the medical expertise nor with training to look after him. I think that's quite important to recognize. Many people want to die at home, and if at all possible, if that's people's wish, I think everybody said, and I would certainly agree, that should be facilitated as much as possible. But many other people cannot die at home for various reasons. One is, in this borough, they don't have families. My family lives in a different country. My partner's family lives 24 hours flying time away. So there's anybody, that's a reality faced by so many people in this borough. I'm an immigrant, white, from Ireland. That's where my family is. And I look around my neighbours, valuable people who live from elsewhere, they've come here, and families are often just not able to look after people, no matter how much they would like to. So the question of hospice beds is not going to go away. No. Looking at one valuable thing in the paper, many valuable things, but there's one long-term look at where we'll be in 2040. That's 18 years away. In terms of planning, that's quite important. We take a long perspective, because what we don't want is to produce something which is like a bandage for now. What we're planning is for something which will go forward in the years to come, when there are more older people. We know that there'll be more people with dementia, with comorbidities because of age and so forth. So the choice needs to be looked at. And to use Amanda's words, and she's right, the system itself needs to look with more imagination to meet changing needs of people, rather than simply replicating what we currently have. Staff, I think, is interesting. We are short of staff who might run Pembridge, but we're short of district nurses. Keith mentioned people didn't come. There simply are not enough on the ground staff either. So I think in the next iteration of the paper, there needs to be an accurate description of what our staffing position now is, what a staffing position would be that we'd like to get to over the next few years, or 5 years and longer, with the growing older population. And we need to actually look at finance, because finance will not go away. And it's not simply saying use resources. We all say that, and it's quite right. But planning an advanced system requires investment. So as part of going forward, listening to people and talking to people, we need to look at actual staffing, planned staffing, look at how the whole system, not just the community care, will work. Because some of the most valuable people who contributed were from Imperial Hospital. We had some staff from Chell West as well. We know the big room at Imperial is doing a lot of work, and that needs to be an integrated system, because we're really fine segments with that integration. And if that happens, the people who have poor debts, who are many, there'll be far more of them. So we have a chance to integrate here all the facets of the service, and I think we should take the opportunity to do so. Then we will have far more people with good debts, far fewer people dying lonely with untrained carers looking after them. So we have something here. And I think we need to take it forward with a lot of listening. And what will come out will be not one plan, but a multi-pronged plan to meet multi-needs.
Thank you. Thank you very much, Jim. Before I invite Meryl, I know that Michelle, you raised your hand while Jim was
Yeah, I'm happy to talk to the points that Jim has made, if that's helpful. So Jim, thank you for that. And I think I guess I just want to give the assurances that the model of care working group is currently trying to do exactly that, is look at what we have as a workforce as a totality for us for community specialist palliative care, as well as apply robust as much as possible data that we have around our health population needs and what that will look like for the next 5 years, so that we can then map out what is the workforce that we're going to need to support that. In addition to that, understanding that we need to probably do something a bit dynamic that looks at a workforce that isn't just more of the same and considers other options, looking more at GPs potentially with a specialist interest in palliative or end-of-life care and how that's delivered, and really trying to kind of make sure that we've got the right staff going forward. And then in addition to that, just to say, I'm not sure when your next meeting is, so I want to be able to say that we'll have the data available for that, but I'm not entirely sure that we will. Just to say, we will obviously try and work to your request about laying out that workforce data, but we are currently going through an iterative process with our model of care group and the providers to obtain that data and then work up what the options might look like around first identifying what good looks like, then how we can possibly deliver that and what workforce we need, and then what the operational delivery will look like. And that's where the consultation piece might need to come into the fore, that if there is something significant there, then we would need to go out to consultation around what those options might look like. But again, just to give you assurances that we've heard the need around people living on their own, not necessarily wanting to die at home or being able to have the option of dying at home for social reasons or equipment reasons, and therefore not being eligible for hospice. What does that then leave them? Is it a care home? Is it going into hospital? And those are the kinds of conversations that we're having at the moment around what are the alternative bed arrangements for the wider palliative care set of needs, as well as the community specialist palliative care hospice beds, if that makes sense.
Thank you, Michelle. Yes, our next meeting is in November, and after that it's going to be in January. So
I would hope that we've got something for you by November, and we will definitely work to that. So I'm happy to take that away as an action for us.
Thank you very much. I would now like to invite Meryl and then Lisa. Meryl?
Hi there. I think I'm supposed to introduce myself, although most people around the table know who I am. I'm Meryl Hammer. I'm Secretary of Hammersmith and Fulham Sabar NHS. And like Jim, I have worked very closely, both at North West London level, but particularly at Hammersmith and Fulham level, on the palliative care issues. We were heavily involved in the earlier 4-borough issues around Pembridge. The first thing I'd like to say is that Jim and I have regretted the fact that we're not on the model of care working group. This is because it was taking place at the time of year and it's a bit hard to be involved in meetings when you're in the west of Ireland. So it's also why we're having a bit of a wobbly connection at the moment. So
Meryl, can I suggest that maybe you turn your camera off? Would that improve the connectivity?
I can turn the camera off if that makes it easier. I have got a wobbly connection at the moment. Secondly, can I just, I don't want to repeat what Jim said, but except on one thing, and that is how positive an experience it was working with Shaksu and with Philippa on the borough-based work, because I've frozen, I think.
You can still hear you.
You can hear me, okay.
Yes.
The working at the borough level on the work on palliative care was an extraordinarily positive experience, and one that I think was an example of genuine co-production. And it would be great to know that that sort of approach is going to go ahead. I have one significant concern about the report, which in many ways I think is a very good report that covers issues very clearly. But at one point, and I'm afraid I can't access it at the moment, it actually talks about consultation possibly happening if there's a significant change in service. Now, we've always been told if there is a significant change in service, there will be consultation, proper full consultation. I want reassurance that if there are to be any significant changes, there will be public consultation. Thanks.
Sorry, I can answer that quickly. Yes, there will be. Absolutely.
Right. Can you actually look at the wording of the report?
Yes, we will. Yes, definitely. Yeah.
Thank you very much, Meryl, for raising this. So just so the reassurance and everyone's reassurance, is going to be
there is a significant change in service, there will be a full public consultation.
There will be a full public consultation.
Yeah, yeah.
I just clarify that point because it's very. This is really. I'd say before I do, just want to say how pleased, given where we were when the first work was done on palliative care and closing of in fact, the unfortunate situation we were in, the complaints made about how the NHS wasn't engaging properly. How really nice it is. The NHS has listened and grasped the opportunity to do things differently, and hearing these great comments about how you're doing it is really, it's very welcome. Can I just clarify that about Pembridge? I'm sorry to come back to Pembridge, but if I may just clarify, I appreciate the difficulties you've explained in finding a specialist palliative care consultant to run it. But if we're talking about significant changes and consultation on those, would the either closure of Pembridge or not improving it beyond what it offers now count as a significant change which would require consultation?
Yes.
Thank you. And the other question I had, which is that's very helpful, and also, by the way, it's a fantastic answer. Just the brevity of it. I
think Andrew.
It's nice to hear.
It's a great answer.
No.
The answer. And the other
I think
thing,
Andrew has more to say on that point around the consultation.
all right,
Yes.
okay, I'll take that, Andrew.
Yeah, so obviously one of the roles of scrutiny, and obviously there's a JOSC in Northwest London, is that when we come to decide wherever the level of consultation is, that we will discuss that with the scrutiny and the JOSCs, and they will help us determine the way that we go. So before any decisions are made on that, we will be coming to you guys to talk about what we're proposing and what any consultation would look like.
Okay, that's interesting. It hadn't occurred to me that you might be needing a very small, limited consultation as opposed to a broader one. And so it would be good to have, I would appreciate also as the cabinet member, having an understanding of what you're proposing. Thank you for raising that point, Andrew. Would that be okay?
Yeah, for sure. As I said, there's no decisions have been made as yet, and we're saying that if there's a significant service change, we would have a full consultation. But that part of the process that we have to go is to discuss that with the scrutiny committees, with the JOSC, before any decisions are made.
Yeah, thank you. And the other thing is just about money. If you were able to find happy events, if you were able to find a palliative, and I appreciate you're still looking, appreciate that you were able to find a palliative care consultant for Pembridge, that would enable you to reopen Pembridge, and it would take a certain amount of funding. And you have, if I'm right, you don't have any new funding. So although is that not right, Robert? That's great. But that's
no, we don't have any new funding at the moment. No.
So thank you for clarifying. So confirming that. So if you don't have any new funding, and your report came up and said we should ideally have all these things to really provide the full range of services which you're trying to achieve, but we can't because we don't have the funding for it. What could happen then? Is there an opportunity to go for greater funding?
I suppose part of what we need to do is be able to, if that was the case, was to be able to develop I guess, a business case that would demonstrate that less people would be in hospital, as in general hospitals. So therefore, some of the money that they are paid at the moment could be reinvested back into either hospices or community-based services. But we would have to be able to demonstrate that, because at the moment, a significant amount of people die in hospital. Yeah. And the hospitals get paid a tariff for that to happen. So what we would be saying is that money should be reinvested back out. We'd have to be able to demonstrate that.
That sounds eminently sensible, and that's something that you would be prepared to work on doing if you felt it was the right thing to do.
We would absolutely be prepared to work on doing that. We're not going to make the decision on it, but we would be putting forward a case. Yeah.
Good, great.
Can I just add to the point around the Pembridge consultant, just to reiterate, as Janet mentioned earlier, the money for the consultant cover or the Pembridge service has been ring fenced, and we are currently using that to provide provision in other hospices. So if we were to find a consultant before the review were to end, there is funding available in that budget to then fund that specialist palliative care consultant, if that were the case. So we haven't taken the money away, it's being used to support reprovision at other hospices, as well as bolstering the Pembridge community support. As we know, during COVID, there was an increased demand for community services. I don't know, Philippa, if there's anything different to that, but I think that's what we've agreed.
Yeah, no, I think that is a good articulation of the current position. The other thing I think the committee should be aware of is, obviously we have had a long period of that service being suspended, and through that period you obviously lose nursing staff as well. So there is that current position. So we are working on a position of what we would have to do to open that service, and it's not something you could switch on immediately. So I think that was just to signal to the committee, there is an operational challenge there, but the money is there, and as soon as we've got clarity on model of care, then I think we can move that forward.
Right, that's great. So the money, just to clarify, if I may, that's really helpful. The money for the nurses is also, as it were, ring-fenced.
Yes.
Great. Thank you very much.
Do we have any indication of timeline to this?
I'm happy to take that. So we originally had a timeline to look at getting the model of care work done around early August, September. However, through the engagement that we've been doing and similar scrutiny committees like this, we have heard how important it is to do this work well, also recognizing how complex it is and how many providers we have to work with, and the sort of dynamicness of the improvements that we would be having to do. So there has been conversation about possibly extending the timeline, which I would like to flag that is something that's going to happen, with potential of going out to consultation, if we did, only next year in around March, April time. So we have still got a way to go, and I appreciate that this has taken some time to get us to this point, but we have taken on board how important it is to do the engagement appropriately and to take the time to do the work properly. So that is where we're at with a timeline in terms of consultation, if it were to happen.
Thank you.
But I think yes, that we give you, and I'm very happy to do it, regular updates in November and January to tell you where we are on the journey.
Yeah.
Okay, it's a good action going forward. Thank you very much. But Lisa, I know that you wanted to.
I think with a lot of my points, but just to say, given the workforce challenges, it feels like there needs to be a lot more focus on the workforce and an innovative approach to it in this, and it may be detailed elsewhere. But in the key points for Hammersmith and Fulham, I think that workforce is critical, isn't it? In this one, is it, as Jim said, in so many other areas, and there's not much detail there. So I'd be hoping, is there detail somewhere else?
So as I mentioned, Lisa, before, to Jim's point earlier, we are currently working through getting workforce establishment and understanding what our current workforce across North West London is for all of our providers, as well as then understanding what that means with on-call arrangements. And it's a very layered system. And we would then be looking at that in the model of care working group over the coming weeks and months. So I would, as I said, hope to have something with detail that we can give you for the November update that shows what is our current workforce in the least, and hopefully maybe by that point would have started to look at how we might use the workforce future modelling and options to come up with something different. It just all depends on where we're at with the model of care working group tasks, if that helps.
No, that does, and I think a line to that is I worry about the use of the mention of care homes as community-based provision for this type of care, because we know that we struggle with quality of care is fact in our care homes at the moment, is fact. And I think that again with the workforce, this is something we've that's got to be looked at in great detail, because it's not going to get better overnight. Absolutely not. I think the quality of care in the care homes, and I wouldn't want it to be, I mean, as most people have said, it's very specialist care. Sometimes family and friends want to get involved, and that's also fantastic as well. But I also wouldn't want it to see given to and I'm not suggesting it is, but be given to very untrained carers who don't have a clue about the complexity of this, because again, we're all facing it, health and social care, real challenges with getting the right skill level out there. So a bit worried about, so workforce feels very big. And then my final point is, and take what you said, Philippa, about the longer Pembridge is closed, the longer it feels closed, if that makes sense. And I know it was used during COVID as to help with COVID positive patients, but that feels difficult one to communicate on really in the midst of this. That remains closed, but actually the plan is potentially not to keep it closed. It's just quite difficult, I think, in the midst of this model of care and this consultation.
Yeah, I completely agree, Lisa. It is really difficult, and there is a Pembridge community team that's very active. It's difficult. It's difficult for them as well, and it's difficult to keep the team motivated and forward looking. But I think we kind of are where we are, and I think that's just what we've got to manage together, isn't it?
Yeah.
Okay, well, thank you very much. There are no further questions or comments. I would now like to just note the actions going forward then.
Sure, Chair. We have one from Councillor Quigley who has a suggestion about how carers can be better empowered to support their loved ones at the end of life, and Robin has agreed to connect with Councillor Quigley outside of the meeting. Sorry, I'll try and speak up again. So as I said, Robin is going to be connecting with Councillor Quigley outside of the meeting about her suggestion as to how families and carers can be better supported. The second action was around the data being made available by the next meeting, which is the 16th of November, and whether or not there'll be enough sufficient data to suggest going out to formal consultation if that is the case. And then obviously please do let me know if you want me to refine that even further. We can talk about it outside of the meeting as well.
I think that just needs a little bit of correction.
Yeah.
Just to refine that one. So I think the data is around the workforce specifically.
I was coming to, I've got
So
to go
just
on
to
that one.
correct that, yeah, just
it's
correct that
kind of
action.
moved around a little bit in the discussion, and there was the workforce point raised initially by Jim, I believe, and around a regular update will be referred to for November's and January's meeting. Yeah. Okay.
Can I just add to Janet's point? So just with the data, it's not the data that's going to determine whether we go out to consultation. It will be what the options are that the model of care working group is going to come up with, which will then be appraised by the steering group. And then, as Andrew mentioned earlier, there would need to be a discussion with the scrutiny committees and about what that looks like and whether it's significant enough and what the length of the consultation would be. So just a distinction there on that.
Thank you.
Okay, well, thank you very much.
I just wanted to make one final comment, because I think obviously, Jim, you've sort of, I don't want this to sound like it's a mutual appreciation society, but I'm going to say it anyway. But obviously, Jim, Meryl and Marion, who have been sort of instrumental in sort of, I guess, leading us to get to the right engagement. And I think Chaksu has obviously been a key component in that. So I think we set out as a health and care partnership that this is how we were going to do it. And I think, you know, we can't go back now. I think we're on the journey, but we're definitely on it, aren't we?
Yeah.
We can't get off that train now. So thanks to everybody that's been involved.
Thank you
I
very
think
much.
Marion's on our model of care working group as well. So we do have a Hammersmith and Fulham voice. And I know obviously Meryl and Jim expressed their disappointment about not being able to be part of it, but I hope through Marion that you're getting some feedback, and we're happy to support going forward. We're planning to put information about the model of care working group publicly available so people can read that as we go.
Thank you very much, and thank you as well for ending the note. I think it's really positive to see from the examples that we've heard this evening what co-production is all about, which I know something that we're really proud of. So it's really good. Well, thank you very much. Thank you, Philippa, Sue, Robin, Michelle, Andrew, Chaksu, Janet, Meryl, and Jim. I think that's it. Yes. Great. Okay, thank you. Before we move on to the next agenda item, I wanted to ask members of the PAC, are you happy to have a 5-minute comfort break?
No.
No? You want to carry on?
No, we can be brave here.
Okay, let's be brave then. Great. Thank you very much. So let's move on to the next agenda item 6. Hammersmith and Fulham Safeguarding Adults Board Annual Report 2020-2021. And we've got with us this evening Mike Howard and also Cassia. Thank you for your patience.
Good evening, everybody. My name's Mike Howard. I chair the Safeguarding Adults Board for the Borough. I also chair the Children's Board for the Borough as well. So you might come across me wearing one or both hats. Pleased to present the annual report. In our former, this is the 4th annual report for the board. It's going backwards in some way in that it's a traditional paper-based report, which is disappointing because the previous 2, we've been very innovative in that, thanks to Lisa, we've commissioned a couple of independent filmmakers who have brought the report literally to life, and it's still on the website if you care to look at it, for both previous 2 years, where they interviewed, and Shiazi was one of the people that was interviewed, and so was I, talking about their experiences of safeguarding. But most importantly, there's 2 excellent examples of people who have experienced safeguarding. One is a woman called Lisa, who was a rough sleeper, describing her life spending 7 years on the streets of the borough, particularly in the underground station. And before that, there was a chap called Andre, who was in his late 40s, and his sister talking about their experiences in care homes. And if you do get a chance to look at them, please do, because they're both quite moving in their own way. And, you know, it cannot, as much as we work hard to do this report, there's no substitute for actually hearing from someone's experience of being a rough sleeper or trying to get the best care for her brother. But onto the report that you currently got in front of you. We have tried very hard to make it informative, easy to read. When I was setting the brief, almost like a magazine, because I've been doing this job a long time and I've seen many of these reports. maybe I've been responsible for one or two, which look sometimes a bit like an academic tome. And, you know, the sort of thing you might have studied at university. And they're very dry, they're very well-meaning, but they don't actually come across particularly well. So we're very lucky to have the services of an excellent graphic designer called Alison, who's really helped put this report and bring it to life. We tried to concentrate on what we've done in terms of the so what question, which in safeguarding always comes up. Well, you've done this, but what difference has it made? But before we've got onto that, it is important just to make sure that everybody understands what safeguarding is. Because if I'm to go outside and stop someone in the street in King Street and say, what is safeguarding? They look at me like, what do you mean safeguarding? It's a professional word. So we've tried to explain it's looking after people, it's caring for people, it's protecting people. These are the words that the average person uses. They don't use the word safeguarding. And the other point, and you've spoken a bit about it this evening, is about COVID. This report is elastic in its year. I make no apologies for that, because when COVID struck in the spring of 2020, as it describes, the board sort of closed down because everybody was just doing everything they could just to cope with COVID. And it'd been very easy to just have 30 odd pages talking about COVID. But there's still safeguarding needs. Just because some people have got COVID, there are still people who have got needs. And that's what we've tried to explain in the report. And then all of a sudden, everybody's evacuated, not everybody, a lot of people are evacuated from Afghanistan, and the borough has to mobilise almost from scratch a response. And one of the things I want to do in the report is that there's a lot of assumptions that these boards, whether they're for children or adults, are local authority boards. They're not. The local authority is certainly the key player in this, but there are a host of agencies who are responsible for safeguarding. So it's very important that people understand that responsibility is shared, and it has to be shared. And the examples that we quote in the report are really good examples of how agencies have come together to safeguard people from a whole different range of areas, whether they're from Afghanistan, whether they're trying to prevent suicide, whether it's the risk of death by fire, or all the other things that are in there. You know, this is what we try to do. So you'll see that we've just summarised on page 6 what we've discussed over the past. As I say, it is an elastic year, so forgive me, a bit of artistic license or poetic license there. But you'll see about the response to COVID, what the partners are doing, resilience plans for care homes, discharge at speed, the impact that had on care settings. Then there was suicide, which we led on, and the leader of the council, there was a meeting he convened, talked about the Afghan refugee evacuees. So that really sort of gives you a flavour of the range of subjects that the board looked at. What is safeguarding? Hopefully that explains it, but if you'd like to know more, please click on the link and you'll see someone from the Advocacy Project talk about it. Many of you in this room are very familiar with the borough, but I'm conscious that this is written for people who may not be familiar with the borough, or like some of our health and police colleagues cover other boroughs. So we've got a few facts about the borough in terms of, they're all there, I won't go through them. Mentioned the variety of the board. I think it's important just to single out one or two. HMP Wormwood Scrubs tend to be overlooked, but you know, many years of trying, I've finally got someone from HMP Wormwood Scrubs to sit on the board at Deputy Governor level. And the other one is DWP, Department of Work and Pensions. Again, a bit of a battle, but we finally got somebody on there. I also have to commend colleagues from other local authority departments, particularly housing. I've been doing this job a long time, and I have to say that the engagement from the housing department, from Mark Meehan and his colleagues, is as good as I've ever experienced. And housing is a key issue in safeguarding. So having Mark and Simone and people like that is a real, and the other is both training standards and community safety. So it's not just Lisa, adult social care, you know, it's people that you'll know, other directors and other senior people within the local authority. and the range of health providers as well, plus the police and the fire brigade, and not forgetting the voluntary sector. So you'll probably know far better than I do about everything that's been done about Afghan evacuees, but I think it's just important to show how everybody has come together, where it's housing, health, public health, adult learning skills, etc., to help these people and the resettlement. And there's a nice little example there about Christmas at a bridging hotel. Obviously, these people come from a country don't have Christmas. What does it mean? It's a big thing in this country. So just to try and help them understand what Christmas means in this country. Suicide prevention. This is something that we've led on. It's very sad, the number of particularly young men who feel that they need to take their lives. That's the only solution to their problems. So a lot of work has been done there. Hammersmith is one of the leading local authorities with this Ripple project, which is described there, set up in very tragic circumstances by Alice Hendy following the suicide of her brother. Had to mention something about COVID. So it's all there on page 16, talking about what everybody has done. And also an interesting one, which we put in there about the safeguarding response to fatal fires. Hammersmith has had 2 fatal fires in the last 2.5 years. A huge amount of work's been put in with the London Fire Brigade, adult social care and others. But these examples are in there because we're dealing with adults who have free will. And the report then goes on to talk about mental capacity. But in both these cases, the victims chose the course of action they did. They had all the fire retardant blankets and all of the necessary paraphernalia, care lines, etc. But their life choice was to carry on smoking, even though they were immobile or whatever. And sad to say that was the consequences. So I put it in bold that the freedom of choice is fundamental to the work of safeguarding. The only way we could have stopped those people was literally to take away their liberty, which you can't do. So people are free to make choices, and sometimes those choices are not what you might choose to take, but that's what they choose to take. And in these cases, there were tragic consequences. And then that goes on in a bit more detail to talk about mental capacity and the deprivation of liberty. There's some statistics in there which I won't go through because they're there to see. We've tried to make them as straightforward as possible in terms of their layout. So you can see them all there. It's very important, page 26. Everybody assumes abuse is about physical harm or the threat of physical harm. Yet the board always talks about other forms of abuse, particularly financial abuse. If you look at our previous annual reports, you'll see some interviews with people like Doug Love from Trading Standards talking about their work. Valerie Simpson, she was talking about her work. You know, it is getting more and more publicity because these people prey upon vulnerable people. My own mother and father were very nearly victims of this. So, you know, it's important to think about other forms of abuse, and there's other, they're all listed there. Also, the police do a lot of work with their different group of scams, and then there's some more statistics about making safeguarding personal. Now, this is a key tenet of what we do as a board. We want to make sure that any safeguarding intervention works for the individual, and what would work for me may not work for somebody else. And it's all about this whole idea of make sure that I am the center of it, not I know what's right for you. Well, no, you don't, because you're not me. But I do know what. No, you don't. And so it's this way, and you can see that how we've tried to make sure that we have listened to people. And then to conclude, there are 2 case studies which are just so typical. They are fictitious in some ways, in that the names are fictitious, but sadly, the self-neglect is far too common. I think there are over 400 referrals to adult social care a year in this borough alone for self-neglect. So that gives you a feel for what the different local authorities, whether it's health, whether it's the council, would do. And then you've also got another one about financial abuse, because that is far too common. And we use this as an opportunity to highlight things like lasting power of attorney, which we would certainly encourage anybody to take out. Direct payments, so people know what that is. And then lastly, finish on a high, as they say. The council re-enablement team, that excellent work they did, transferring residents from hospital to their homes during COVID. So that is the annual report for this year. Thank you.
Yeah, thank you very much, Mike, for the summary. I think it was a fantastic report in terms of the infographics and the case studies. It's great to see as well how different stakeholders and work together, not in silos, but work in collaboration. You mentioned health departments, local authority, emergency services, the voluntary sector, and other statutory sectors. So it's really positive report and very informative. Thank you so much. Before I go to you, I noticed Victoria had her hand up before, so I'm going to ask Victoria to come in, please, Victoria, and then I'm going to go to you. Victoria?
Yeah, thank you. Thank you for your report. I want to mention two things. I'll try to be brief. You mentioned that it was the choice of on the subject of the fires. You mentioned it was the choice of those two people to carry on smoking. I think we need to accept that what motivates people to do things is a very complex area. And yes, it was their choice to carry on smoking, but people's choices are influenced by a number of factors. And it may be the case that those two individuals, their lives were so miserable and so empty in other respects, and so stressful in other respects, that smoking was the only pleasure they thought they had. And I think in those kind of cases, the agencies involved with those people, with people like that, have a responsibility to try and minimise the stresses they face and to increase their quality of life and the amount of joy they have in their life, to make it easier for them to make the right choices. So yes, it was their choice, but it may be that agencies could have done more to make it easier for them to give up smoking. My other comment and question is about something completely different. It's been widely reported that domestic violence increased during the pandemic. And can you tell us a bit more about what the Safeguarding Board has done in the area of domestic violence? And next time you publish the report, would you be able to devote a bit more attention to the issue of domestic violence, particularly violence against women?
Well, I'll deal with your second question first. We don't specifically deal with domestic abuse. The reason for that is that one of the members of the group, Matthew Hooper, who works very closely with other senior council colleagues on the violence against women and girls group. So we feel that we should defer to the work that Matthew does through that group. He also is our Maynard Gordon is on that group from Children's. So whilst there is nothing specific in the report about domestic abuse, that's not to say the board hasn't considered it. And we recently had a discussion about how we could work with the violence against women and girls group. Our concern really is violence in families where particularly someone is a carer or is being cared for, and maybe because of quite understandable reasons, the pressure, and it gets back to some of your earlier conversations, causes them to use an expression just to sort of lose it. There's also cases of domestic abuse between children and parents, grandchildren and grandparents. So we feel our role on the board is to make sure that domestic abuse tends to be associated with violence, abuse. It's not just violence, it's whole forms of abuse between people who are either in or have been in an intimate relationship. And it's a much broader definition. So the role of the board, and for both boards actually, the children's and the adults, is to defer to the violence against women and girls group through board members that sit on both panels. We don't feel that there's much to be gained by duplicating work that's happening elsewhere. but that's not to say we don't take recognition of it. And to give you a really practical example, the domestic homicide reviews that are commissioned by the Community Safety Partnership all report into Safeguarding Adults Board. That's a change that I brought in because in recognition that we have a role to play in overseeing the implementation of the actions. In response to your first question, I think in fairness, if you read the report, it says there were 4 visits per day for care workers. There was a huge amount of investment in time in those people. The risk of fire was seemingly understood by the victim, but nevertheless, she chose to take the risk. I don't feel qualified to say what more could have been done to make that person feel that they didn't need to smoke. I've never smoked, but I understand nicotine is the most addictive substance there is. And for those that have, it's a very difficult habit to kick. So I don't feel qualified to say any more than that. Maybe Shazia can or Lisa, but that's my response to the points.
Thank you, Victoria. Thank you, Mike. I've got Keith, please.
I've got 2 points actually. Sorry.
Well, you first them.
I'll let you go first.
2 points actually. You talked about the composition, and I noticed as advocacy services. I would have thought someone like groups like Mind would have been important members to sit on this. I'll tell you for why. I worked for Mind. We also worked for a project with vulnerable families. I've had cause on several occasions to raise safeguarding issues. I have to say, when I raise them within a council setting, the council here responds positively. Sadly, West London Trust does not respond positively. I've been told by the crisis team, what are your qualifications? What do you know about safeguarding? Who are you? And I've had then to escalate it to top management. That is not good enough. The crisis team should be able to answer and take comments seriously. So much so that there is a case before the coroner at the moment where one of the patients went into Charing Cross, accident and emergency. Someone came across and saw him, said there was nothing wrong, sent him home 3 o'clock in the morning, and he promptly committed suicide. Now, I think the trust, West London Trust in particular, has really got to get to grips. I'm sorry, but I'm just not happy.
Well, that's not a question for the Safeguarding Adults Board with respect.
They're a member of your
Well, they're
board.
a member of the board, but we are not looking at, that is an issue, as you correctly say, to be taken up with the senior management of West London Health Trust regarding that specific incident. In terms of your point about Mind have been members of safeguarding boards in the past. The problem that they have is just capacity. Many of these voluntary organisations cover quite large areas and they just don't have the capacity to sit on the boards. We do have a voluntary sector coordinator, Sonia Benitez, who is on the Carers Network, and she acts as our coordinator. You're right, we do have the advocacy project, but it has to be said, Keith, I'm afraid that because of pressure of work and time, some of the voluntary agencies are very occasional attenders.
Yeah, we are stretched, but
so we
get people coming to us as a last resort, because it's been shoved away by others. We don't shove them away. We take it on.
That's the reality, I'm afraid.
In relation to the concern that you're raising, with London Health Trust, how can we mitigate this concern that
needs to be raised with the chief executive of West London Health Trust?
Yeah, so that's Caroline Regan, really. So we'd have to raise that this came up at the board, and yeah, we'd have to raise this concern.
We don't have people of that seniority sitting on the board. And it needs to go to the top.
Maybe it's just-
Well, obviously, it needs to go to the very top.
The chief executive.
Well, no, he said he wasn't happy with the trust at the inquest.
Cool, so we have that as an action. Possible. Thank you very much. Councillor Ben Coleman.
Hi, I've got a couple of questions. It's regarding the suicide prevention on 15. What I haven't noticed is any statistics on those that commit suicide, because we're talking about men predominantly up to age of 35. I've never seen in this borough statistics for suicides or attempted suicides. And the reason why I ask is why, whilst I would hope it's rather limited, I'm sure it's not, as I get a lot of emails from residents who live close to Putney Bridge, and the police are there a lot where somebody's decided that that's how they go in their life. Clearly some are more successful than others. The reason why I ask is because a lot of these suicides, or attempted suicides, I should say, are preventable. And we need to be making more of a concerted effort to put measures in place so that we potentially reduce that number. And we shouldn't be having any, in an ideal world, we shouldn't have any. Now, as most of you know, I'm a psychotherapist, so I have some sort of understanding of this. But we need to be doing more with the limited resources we've got to actually reduce these, which is preventative work, get people before they get to this stage, which may also just going on. So it's a bit of a, if we have some figures, that would be really useful.
Could I just ask, because I'm glad that Nikki's still here, because she sits on the board, but she leads on the suicide prevention group. And I'm sure she'd be pleased to tell you what has been going on, because a lot's been going on. The second thing is that there are figures, but they are extremely sensitive.
Of course they're sensitive.
So this is a report which is the public. So we can't include figures like that because there aren't that many, but if you actually put Putney Bridge Station and it's not that difficult to identify the person concerned. So we are very aware of that. So that's why it's not in this report. Nikki can tell you about the work of the suicide prevention group, and they may
Can I just say in that regard, we are predominantly elected councillors here. Yeah. If there is a document that is produced that is not for public scrutiny, then it doesn't go any further. So I think it's quite reasonable that we actually have some information about this, because we talk about it, but we don't actually get. Well, yes, I know. Thank you. Yeah, thanks.
Dr. Lang, please.
We're not being carried away yet.
Hi, Councillor Lloyd Harris. We're probably 2 weeks away from publishing it, but I can just send it to you via email. That's completely fine. It's been signed off by Safeguarding Adults Board. The reason that, as Mr. Howard has said, we haven't published it yet is we're just waiting for Children's Services to refine their recommendations, but we're very, very close to being able to publish it as part of our joint strategic needs assessment. And as Mr. Howard has said, it's a super important piece of work.
Okay, that would be really useful to have a copy. And if you don't want it in the public domain, please put it on the email. That won't go any further. So that would be helpful. Also, the comment about the 2 fatalities, the fires. Now, it says in the report, somebody evaluates risk. Now, I'm just wondering, in these sorts of cases, if somebody is smoking, yes, there is obviously a potential risk, but that's their choice as to whether they smoke or not. I'm just wondering, when the assessment is done, do we also do an assessment on, say, hoarding?
Yes.
You do, because that is obviously a problem if somebody is smoking. So that is covered,
That's
right?
a joint piece of work with, I think the housing department have 2 dedicated fire officers, together with the London Fire Brigade.
Fabulous. One last question. Sorry.
We also have a high risk panel as well. Okay. Which is was chaired by the London Fire Brigade Commissioner, but he's moved on. So we've had a
bit of a churn with
but that's
been a revolving door, to be blunt.
We have a high risk panel as well. So these are cases that are, like this.
Okay. One final quick question is, You've got in your graph here about that mentions income deprived on page 9. Do you have a definition of what income deprived actually means? What does
The
poor
short answer to
mean?
your question is no, because these statistics were provided by, is it the BIS? And I think BI
team, yeah.
And I think that's a fair question to understand what that means. So I can't answer that question, so I'm not going to try.
To get at some sort of definition of what that is, because it's something, as we were talking actually before the meeting started, that is cropping up in a number of areas across the board, across the borough, I should say, as to what actually is income deprivation. And you know what it might have been 50 years ago, it was definitely not what it is now, but it would be really helpful to have some idea of what that looks like.
That's a fair question, yeah.
I think the cost of living crisis as well,
Yeah, but we don't know what that is. For somebody that's worth billions, you know, if they've only got X left and we could look at that and just laugh and think, oh, that's so much money. They may have a different sort of view of it. So it is relative, but it'd be helpful to actually understand.
Before I come to you, Councillor Coleman.
No, I was just going to say, I think it's probably best to share reports with our bench councillors once they're completed. And that's what would be my recommendation to the Director of Public Health. If you're 2 weeks away from completing the report, it'd be delighted for you to share it with anyone who wishes to see it, but I would suggest you complete it first and then share it.
I think that's all that we assume they wouldn't be sending it out now when it was concluded. That's what I took it as, sorry.
Good.
And I'm actually not a backbencher.
Sorry, opposition.
Opposition's fine.
Opposition.
Okay, thank you very much.
No,
Bobby.
that's not true.
Oh, yeah, sorry. Just a quick question.
Yeah.
First of all, thank you so much for your report. I did know it was, because of the layout, it was much more enjoyable to read.
Oh, thank you.
I enjoyed everybody's.
Thank you.
The colours were great for me. Just a question about the members of the board. So I note that under health, you have a number of trusts, right?
Yes.
But when it comes to Chelsea and Westminster Hospital, you just say hospital. Could you confirm whether that's the trust or just the hospital? Because we've got Westminster.
Chelsea, Westminster.
Yeah, if that makes sense.
Because the college, because the hospital is actually located in Kensington and Chelsea, even though it's in the Fulham Road and probably many of its patients I think, come from this borough, they, strictly speaking, are not obliged to join the board because it's a borough board. They're a bit of a sort of throwback to when this borough was with the other two. However, because of the relationships, they do attend the board, but not at the level of seniority that some others do.
Okay.
But they are members of the board and they have worked with us. But that's the. It's interesting because Imperial is in the same position because St Mary's is at Paddington, but of course they've got other places in the borough. So you know that's where Imperial and Imperial are very active members of the board. And the others all provide services to local residents on the board, like West London Health Trust, and so it is a bit of a peculiarity, but we do have a good relationship with Chelsea and Westminster. Maybe not at
the trust or the hospital. Because
It's,
like you said, St Mary's.
it probably is more with people working at the hospital than the trust.
Okay, that's what I asked. Yeah.
But having said that, councillor, I think that because I've been doing this job quite a long time and know them, and there's a degree of stability there, if myself or Lisa needed to escalate it, I think we could quickly find the person we need to speak to.
Okay.
But they're more likely to have more of a contribution to the Kensington and Chelsea thing than they are to us. But they are members, albeit not as active as some.
Yeah, I'd say the hospitals that we mainly use are St Mary's, Charing Cross, and Chelsea and Westminster. And then that's how it
Yeah. I just to clarify, that is just Chelsea and Westminster Hospital, not Chelsea and Westminster Hospital Trust.
Chelsea and Westminster Hospital.
Okay. Because the trust includes West Middlesex Hospital, so it's just like St Mary's.
Yeah, no,
That's why I asked.
I think that was one of the problems, is that the person we used to have the relationship with, she transferred to West London, West Middlesex, get all these Wests.
Yeah, I know.
And that
Yeah, no,
sort
you're
of
right.
personal,
Right.
I can't remember the name's name now, but it'll come to me. But she moved on, and then we lost that link, but we've still got a link, but not at the level we used to have.
Okay, I understand. Yeah, thank you.
Okay, well, thank you very much. Do you have another?
Oh,
question? Okay, good. Thank you very much. Thank you, Mike. Thank you very much, Kathy, as well, for the report. Can I please confirm follow-up actions, please, before we move on to the next agenda item?
Okay, so the experience that Keith
Can you
has.
please speak up?
Sorry, I'm gonna have to work this one out, sorry. So the experience that Keith recounted earlier on about his friend's son and his suicide and the coroner's involvement in that, this is going to be raised with West London Trust's Chief Executive Caroline Regan. Can I just check, do we have an officer who will volunteer for that, for raising that?
I can do that, yeah.
The second action was to circulate the Dr. Lang, I think you were going to circulate the document on the stats.
Once it's been
Once it's been
published.
Yeah,
Yeah.
suicide
Okay. Is it okay if it's sent to me and I can circulate to the PAC?
It's on the link because it will be put in, once it's published, it'll go on a published link.
So I'll circulate the link. Okay, thank you. And then the last action was a definition of what income deprivation means.
And I'll ask Duncan about that.
Thank you very much. Thank you. Okay, we've got the next agenda item, number 7, Health Watch update, please. And we've got Caroline Duffy with us, Operational Manager for Health Watch.
Good evening, everyone.
And thanks for your patience.
Thanks, everyone. As most of you know, I'm Caroline Duffy, the Ops Manager for Health Watch Hammersmith and Fulham. And I've just realised actually today is a year since I started working in this role, so it's quite apt that I'm doing the annual report.
Congratulations.
I'm just going to pick out some of the points, and then if you have any questions, just raise your hand. So this year we have gathered the reviews of 5,581 people. 264 people called us for advice and information. Mainly this was on COVID-19 vaccination or looking for services that offer mental health support in the borough. We've published 19 reports, the most impactful one of which was the young person's mental health during the COVID-19 pandemic. This highlighted the struggles that young people have been facing since COVID-19 happened, social isolation, the financial impacts that they've been experiencing. And we are lucky to have 34 volunteers from the borough who have given up 338 days this year. The main topics we've been looking at this year is mental health support, which I know is close to everyone in the borough. So we did an IAPT interview, which resulted in IAPT now offering patients face-to-face appointments, telephone appointments, or video appointments. The IAPT team held exercises which were completed in June and July, looking at where they could make improvements, and changes were made on what, and they reflected on what was working well and what was working less effectively and where this can be improved. Our young person study, we have gone on to form a co-production group where we're taking the recommendations forward and looking at the young person's offer in Hammersmith and Fulham. So at the moment we're working with Rethink, and Centrepoint, we're looking at doing some mental health workshops for young people in the borough. We created the local suicide directory for the suicide strategy that was just mentioned. And we've signposted 48 unidentified carers to mental health services in the borough through our carers study. We also looked at primary care access. So GP practices have assured us that they are looking at alternative booking methods, offering online and triage systems while they're looking at long waiting lists and delays due to COVID. We worked to help the GPs actually create multiple languages that increased accessibility in the GP practices, creating leaflets. We've signposted 163 residents to the Digital Exclusion Project so that they were able to book appointments online and avoid long waiting lines on the phone when they were calling the GP. We've collected 384 survey responses for the North West London GP online consultation project, which will go on to the digital and data strategy workshops. We also looked at hospital discharge. So we did a new bedded area in the discharge lounge at the new discharge hubs. We've recommended that we found that patients were being sent home and they didn't have food in their house. So upon our recommendation, hospitals are now asking patients if they have food at home, and if don't, the hospitals provide them with a lunch. We have recommended that they improve communication around waiting times. Hospital transport is obviously a problem, and Imperial are welcoming that we come and continue this work over the upcoming year, looking at where the delays are in hospital discharge and looking at hospital transport. So we've linked up already with the hospital transport team, so we'll be looking at that over the following year. We ran a blood donation awareness campaign, highlighting the importance of Black, Asian and multi-ethnic residents donating blood. These groups often don't donate blood, and there are some conditions where people from these communities can only take blood from these groups. We ran a month-long stress awareness campaign due to the mental health that people were experiencing after the COVID-19 pandemic. We have helped people to find a dentist or a GP whenever they didn't know how to register for one. We have supported the COVID-19 vaccination program. A lot of people have called us up and asked us where the nearest vaccination centre is. And our priorities for next year, I already mentioned one of them, which is hospital discharge we're looking at. And I think most people are aware of us working in co-production with the West London Trust. We're looking at community and inpatient mental health services. So the project has just started, and the first report should be produced by the end of August. And we would hope to come and present that at a later meeting. And we are, as I previously mentioned, we did a carer study. So we're working at the moment on the local authority carer strategy, looking at the strategy for the following 5 years. That's there is some side pieces going on. We're waiting on to see whether bids have been approved and things with the National Institute of Health Research, but they have not been confirmed yet. So I cannot say that they're definite pieces of work, but they will look at trauma-informed schools. During our young person study, we found out that schools are often the first point of contact for children whenever they have a mental health crisis, or just in general for mental health support. And often schools do not have the resources or the training to provide this.
Caroline, thank you very much for the summary of the report. Very interesting to hear about the impact that the different activities have had, and hear about the different projects with accessibility for GP practices, also around digital exclusion and good as well, and the young people's as well initiatives. Thank you so much. Okay, yes, of course.
Yes, I do. I welcome your report. I was a previous chair of the Health Watch before you got the contract, and the comments you've made on Askew Ward, Avonmore Ward, etc. It's like deja vu. It really is deja vu, because the same problems you discovered, we discovered. Not only that, when I worked for Mind, the same problems were coming up. And it was the same wards time and time again. Now, we actually spoke with Caroline Regan. She actually came to a Health Watch meeting and said things were going to improve. They're not improving. And I'm just wondering how you can tackle this, because it really is a long-running sore. I know probably people will think I'm constantly attacking West London Trust, but you know, I have to deal with them. I've dealt with them in the past, and it really is not working in parts. So I'm sorry to have to say this, but you've done a good job in highlighting the problems, but it's almost deja vu.
Thank you. The piece of work that you're discussing is a co-produced piece with the trust, and it's obviously a massively complex area of care. Dr. Chris Hilton has kindly offered to come and join at a future meeting where he'll be very happy to discuss some of the issues that we've looked at as the project goes forward.
Thank you, Karen. Maybe we can have him for a future meeting. Joe, you've got your hand raised. You want to address some of the...
Yes, thank you. Thank you, Chair. I do quite a lot of work with Keith, so I would just support Keith's comments that he does indeed have huge experience of frontline work and some of the challenges with West London Trust. It was actually in relation to that I just wanted to say to Carleen, I think there's some great opportunities for us to do some work together. We've been doing some work outside of West London Trust with looking at how we can co-produce services for those with young people, young adults with autism, many of whom, as you know, Carleen, have, some of whom have other issues to deal with in and around their mental health, particularly when they're misunderstood. And to those ends, and I haven't told Councillor Coleman about this yet, but an autism cafe to try and just find a space for young people to, amongst their peers, there's some experiences and stories about what it's like to be a young person, an adult with autism in Hammersmith and Fulham. It's a growing issue for us that adults with autism are misunderstood within the context of mental health. And I know Keith has much experience of this. So, Carleen, it would be really wonderful to meet with you. I think I've linked in with you on LinkedIn, but I would really like us to sit and talk about some of the projects you've mentioned tonight. I think there are some synergies, as it were, but also taking on board Keith's point, I think there are some issues we could jointly address together as well. So I'll make contact with you tomorrow.
No problem.
Thank you, Chair.
Thank you, Joe. Before I want to Councillor Lloyd Harris, Councillor Coleman, wanted to comment on this? Okay.
Very quickly, I just wanted to support Keith's comments and observations about this report. It's like reinventing the wheel. It just keeps coming. It churns every few years, but we don't get anywhere. And some of these things are very, very basic, you know, about people in units where somebody's making noises next door. I mean, I've had clients, so I've seen that had the parent of a client that was in one of these sort of units, and they just feel like they're locked in there for the day, that there's nothing actually of theirs there. There's noise from patients next door, and it frightens them. And these are very basic things that we could be doing that wouldn't actually necessarily cost a lot of money. And if they keep coming up in reports, it means nothing's done. So whatever you can do would be very much appreciated. Any pressure that can be applied to address some of these issues would be, you know, really helpful.
Thank you for your comments, Councillor.
I was going to comment on the same report. First of all, Carly, thank you for the main report, which is interesting. All the things that you're doing is always very good to hear about, and it's an impressive range of areas. And I do think this report, it's a bit of a shocker. I agree. I mean, you know, I think ASCII ward comes out well, but the others, and you know, the fact that half of the people in the Lily ward don't feel safe, half of the people in Red Sport ward don't feel safe. great that enable more, 100% people say. I know these are small samples, but there's quite a lot in there. And the fact that consistently people say that they don't have fresh fruit and veg and lots of other things. For this come to the PAC, surely it would make sense if we had people from the mental health unit here to ask them questions. I just suggest for the future, perhaps it's something to Basham and anyone, if we're going to take a report like this, it might be helpful because we can't have any conversation about it of any value without them there. So, Colleen, you've given them your report, haven't you? You've given, you did it with them. They've had your report.
No, so this was we haven't completed our first report. I have internal monthly updates that I am using to monitor each stage of the project. But our first meeting with the trust is after we've agreed to do quarterly reports.
So do they know, right? So what's this report then? This is an interim.
Yes, so this was one that was an internal report that we use for ourselves. I think it was just the annual report was supposed to be added, and I think Bathsheba's going to update that the annual report will be added on there.
Okay, and I see. So because I see. So was this perhaps? I'm just being very crude here because it's kind of surprising to have an interim report like this put forward without your, what's going to happen and what they say they're going to do. Is it perhaps was this put in by mistake and the actual annual report should have put in instead?
Yeah.
I'll hold up any comments on this and then we can go forward having a conversation.
Thank you, I appreciate that.
Yeah, okay. That would have been good to have understood that, Shubha.
Yeah.
at the beginning before we all got worked up.
So I would like to add that Dr. Chris Hilton has been very welcome to and supportive of this project and for improvements that the trust can make.
Yeah, no, and I think he's been positive. We found his new approach, the approach that he's taking to be new and welcome. And I think it would be only reason to have him responding to the changes that they're introducing as a result of the findings that you've made. So I think you probably want to do that in a future meeting, but give them a chance to do that rather than us read this down and go, whoa, it's a bit surprising.
So as a follow-up, would you like this agenda item to come back to PAC when we've got that?
Yeah, I think
yes.
We
can also invite other relevant.
We could have West London Trust come at the same time to contribute.
Okay, we can
I
have.
mean, the West London Trust this is a collaborative piece of work. So if I present, I would not present without them. So they will be here to present it.
Okay, so leave it with me, and then we will make sure that it comes back to PAC, and it also has other speakers as well at the same time.
We all did.
Okay, thank you very much, Helen. We've got Jim, Meryl as well, and we've got Philippa. Jim, please, and Meryl.
Thanks. I did not realize either this was an interim report. I assumed it was covering a year. It was the annual report. If, however, as Keith has pointed out and Amanda iterated, this comes back year upon year upon year, would it not be an idea to send this interim report in advance to the West London Mental Health Trust and to ask them to respond in some depth as to why repetition happens? What are the factors which get in the way of change? And are there key recommendations, small in number perhaps, which they might focus on so that the next report will at least be slimmer in terms of what is not working well? And I say this because I know recently the CQC report on the Mental Health Trust was not entirely complimentary, and it did mention safety and so forth.
Sorry.
Thank you very much, Jim. I think that's a good idea. I mean, the report could be put to them and then they could comment.
Yeah.
And then it could also be part of the PAC for a specific agenda item to address some of the concerns that have been raised. So please leave it with us and we will make sure that we will bring it to the PAC in a future meeting. Philippa, you put your hand raised.
Yes, thank you, Chair. Sorry, can you hear me okay? I put my microphone up by my head for some reason. Sorry. just a thought, and this is not to distract from PAC at all, but obviously our borough-based partnership, which Lisa and I chair, has a mental health campaign, and we do have representation from the Mental Health Trust in Helen Mangum as the exec responsible on our borough-based partnership. So I think there's an important piece in parallel that we discuss at our borough-based partnership as well, so that we make sure that we're working collaboratively together. So to have sight of these things is really helpful, because I think we can pick those things up in a discussion there in terms of improvement. So Lisa, if you're happy with that, we should pick that up at our exec and move it forward that way as well. Oh, and just to say, sorry, on the autism front, Joe and Carleen, very interested in that, because we CLCH is a provider of some of the autism and learning disability services, so really keen to collaborate on that front as well.
Thank you, Philippa, for the suggestions. So will this be an action going forward? Yeah. Great. Okay, thank you very much. Are there further questions, comments? No? Okay, so can we please just summarize what the actions are?
Yeah, sure. Thank you. So we've got an action for Joe to contact Carleen outside of the meeting. That's to discuss some of the projects she's raised. The key action here is for the annual report to come back together with the contribution from West London Trust around the interim data and report in that. And a final action was around the point that Philip has just made with the borough-based partnership and mental health campaign, and how it would be helpful to have sight of that data in advance to have a look at the way in which improvements can be made. I'm happy for you to refine that as you want.
Sorry, couldn't get off mute. Yes, just to say we'll pick up the issues that have been raised tonight with the Mental Health Trust in the borough-based partnership. So we're working in parallel with PAC.
Thank you.
Okay, thank you, Philippa. Is that the last one?
Yeah.
Okay, brilliant. Thank you very much. Thank you, Carleen. And okay, so shall we move on to the next agenda item? I'm aware that we've gone past 9 o'clock, so I appreciate your patience. I know as well that tonight is an interesting football match. I know that
it's all right. We're not doing well at the moment, so we can move on.
The Lionesses are playing tonight against Spain. Okay, thank you very much. The next agenda item is the work program. The committee is asked to consider suggested items for inclusion in the work program for the next municipal year. You've all seen as well the terms of reference as well of the PAC. So any suggestions for future meetings and the work program as well are welcome.
Could I ask that when we, sorry, is anyone else? No. But could I, no, just left in. Could I suggest that we actually revert to what we used to do many, many years ago, which is to actually have the items that people come forward with at the end of each report. So there might be 6 or 8, maybe 10 different items. So we can actually start grouping them together that we would like to see reports on those areas going forward, as against somebody just picking one out one quarter and thinking that's great. It's what we used to, it made it just so much easier. You can say, okay, well, there's one there on dentistry, that's great. Then there's something on children's that might relate to that. So those would be useful. Mental health ones, it's useful if you get, say, a meeting where those can be grouped together. But, you know, I'm sure you've been involved in this before, where you get those items that make some sense that they are on the same agenda, whether a major report's coming up. We know that in 3 months' time, this report's got to be produced. So we would like the officers to come to the PAC and discuss it.
I understand that the long list is broken down into categories and themes.
Yeah, if you recall, we've circulated periodically a long list of suggested
but
items.
It doesn't come at the end of each document. You could say, so you've got whatever the number is there, and you could say, okay, well, Keith might say, well, we need something on Health Watch. Well, there's a report coming up. Well, yes, that's one that we would like. So we give the people reporting, or if we haven't heard of a report, like we did with the pool at Charing Cross Hospital, that keeps sort of disappearing all over the place. And we pursued it, and they had to come back with a meaningful report, which they did. That's only because we pushed it. Because we're meant to scrutinise.
I don't understand what you're saying. And
Well,
I
I'm
mean,
trying
I
to
know
say-
you're saying that you should list, you as the committee should have it listed at the end, issues which you've already covered, so you can remind yourselves to come back to them.
No, it's our outside bodies that would produce reports. So we can say, okay, if there's one coming out on mental health, or we would expect something on mental health, then we might look to see if there are maybe other areas that we haven't had updates on for, say, 6, 8, 9 months or something. It's what we used to do.
But the purpose of this agenda item is to do a bit of mapping of.
Yeah, that's what I meant.
topic.
So you could do mapping on, say, mental health.
So
Okay.
the part of the purpose of this conversation is to feed into that.
I go back to Joe's point on autism. A lot of, for some reason, we're seeing more children presenting with autism now. It seems to be suddenly, there's seems to be a lot of autism. And especially there is a link when it comes to housing as well, because that presents a real problem. So I'm just wondering if we couldn't have something on autism, mental health, linked in with the housing issues, because we have problems. People are wanting to be transferred and located. They can't get anything. Seems to me that sometimes the medical advisor doesn't really understand what autism is. And this is something which I think, I don't know what Joe's idea is on that, but it might be useful if she had a little bit of input.
Joe, do you have thoughts on this?
I do. Yeah, that's very helpful, Keith, and agreed totally. Yes, we've relaunched our work on. Councillor Coleman and I started a couple of years ago, just before the pandemic, on our autism strategy, and we've established an internal group, and we're just looking at our co-production now, and the Autism Cafe is part of it. But I think Keith is right. One of the core pieces is around workforce development and people really understanding what autism is and isn't. And we've got a lot of work to do in that arena. But I think it's a very important point you raised, Keith.
Thank you, Keith. Thank you, Joe. So this is noted. Victoria?
Yeah, thank you, Chair. I want to suggest that at some point the committee should examine how accessible our hospitals are to disabled people, particularly wheelchair users. I raise this because of a recent experience of mine. On Monday, I had a hospital appointment, and it was one that required me to get out of my chair and be transferred onto a bed. And asked them to provide a hoist to do that manoeuvre, and they said it wasn't possible. Now luckily I'm quite small, so I can be manually lifted, and luckily my carers that day were people who were happy to manually lift me. But not all disabled people could be in that situation. I think it's an important issue, because obviously if you're a wheelchair user and you need a hoist to transfer onto a couch, then there's no hoist available, then you get the treatment that you need. So, I would like us to examine how accessible our hospitals are to disabled people.
Thank you very much, Victoria. Definitely a very important point. We can examine how accessible hospitals are to wheelchair users.
I was going to suggest that this maybe brings Health Watch in. On that, if for this to be a purposeful conversation, you're going to need to get feedback like Victoria's from quite a number of people. And so we're going to need to capture that first and identify and do what we can to identify whether there's a continuous problem, which is not just Victoria, but also other problems with disabled people in hospitals. So rather than just have a discussion on it, because the hospitals will come out with a load of oh, we take every measure and we do this and that, and we're aware occasionally things don't work out the way they're meant to, but we have all the provisions, and you'll get all that, and we'll go. So what we need is something which leads to change, which first of all identifies as specific an ongoing problem, and it leads to change. Otherwise, there's no point. You wouldn't want to, no one wants to talk about it. So maybe that's something for Carleen to consider as a future area of exploration, is look at the experience of disabled people in hospital. And working, and I know Victoria and we have disabled people, we had a commission, but we have also an implementation group. Patricia is very closely involved with that. And I think that would be, and then, which relates to what I was going to suggest is, if you did that, that could then come back here. But I also think, Carleen, that you're doing quite a lot of interesting work, which I don't get to see enough of. So you're going to keep me more informed. I know that now, which is great. And it would probably be interesting for the committee to be aware of what you're doing, because you're raising a number of issues which the committee can then bring your reports together with the people who are meant to be providing the support in the area that you're addressing, to talk about the findings and to see what changes and improvements they might be making, or indeed have them, be congratulated if it's an excellent series of findings that you make. But I think we could probably make more of Health Watch. Once upon a time, it was used differently by the committee, and you might want to use it to, as I say, take some of the reports, get the people that it's addressed at, and then have a conversation which leads to improvements in the services. It's because Health Watch is putting a spotlight on something, but then if no one else no one else follows up, the spotlight passes on, and the failings remain. So I'd suggest using, Carleen, you might share some of your existing reports with the committee and the subjects, and they could maybe take a view on what's interesting to go into a bit more detail with the providers affected. Related.
I agree. Thank you, Councillor. It does. I do always think we get all of these experiences. We have all of this data, but without the providers and the commissioners, we then have the power to make that change. It's just lovely reports that we produce.
Exactly, and that's part of the problem people have with Health Watch and that's part of the problem because big committees and councils don't use your reports effectively enough. They say, oh, Health Watch is very nice, but it just produces reports. Well, you can't force the committee you can't force us to have people in, but the committee has the power to bring people together and take your report and go through an issue like that. So maybe that's something to consider.
Thank you, Ben. I just want to go back to Victoria. What are your thoughts on Councillor Coleman's suggestion, please, Victoria?
Yeah, I think it's a very good idea that we try and gather more evidence and more data, more experiences. So not just based on my own experience. I would like to make sure though that we do this in a relatively speedy way though, because if there are problems, we need to address them as quickly as possible. So I would suggest that maybe my own organisation, Accessibility, ask our members for their feedback, and maybe Health Watch could do a sort of short-term consultation of people. Maybe we could deal with this maybe at our kind of January meeting. Would that time still sound possible?
Yeah, and we also have a lot of patient experience from the hospitals, so we can search by word. We can look to see if this is an issue that has been cropping up over the last couple of years.
Okay, so are you happy to have that conversation with yourselves and then looking at possibly bringing it to committee for the January meeting?
Yeah, if that's okay with Carly, I think that might be a good time scale.
Great. Okay, thank you very much. Do we have other suggestions, please?
One thing I think we'll probably want to look at, it need to be on top of, is the integrated care system. In July, the 8 boroughs came together. Well, they merged the 8 CCGs a couple of years ago, started to merge them, and they finally went into one CCG, and they've got one clinical commissioning group. And each borough has its own clinical commissioning group. Janet and Sue Rooston used to run ours, and now they've been running something. And they came together, and there's one integrated care system for the whole of Northwest London, which reaches Hillingdon to Northwest Westminster, and it's a work in progress, isn't it, Lisa? It's a work in progress. Yeah. And there is an issue which is shared right across the political. It doesn't matter whether you're Labour or Conservative, across the councils in West London. There's an issue about their understanding of what democratic councils mean, about their involvement of councils, about the way that they're going to make policy. So I think it might be quite interesting at some point to have the ICS in to discuss what they're doing. I can talk to you more detail about which particular angle of it, but I just think looking at
It's a good idea.
I think it's a good idea. This morning, I was actually at the North West London Joint Health Overview and Strategic Committee, and well, I raised it.
Oh, well done.
Yes, I raised it. So, and there were other colleagues as well from other local authorities that were that raised it. So
it's very good because they are going to be saying, oh well, we're going to bring that to the JOS, and it needs the JOS people, all they all need to be really up on it as well. There's a lot of council cooperation in a different way. 8 boroughs are not used to working together on health services, but we are getting much better at that. But it's a big challenge. So I think looking at the ICS, and perhaps a particular issue is how they will decide what should be happening across North West London, the 8 borough level, and what should happen at the level of the borough-based partnerships. And there are 8 of those, and Lisa co-chairs the one in Hammersmith and Fulham with Philippa, who's gone from the NHS and do a great job. So you also might want another report, Lisa, from the borough-based partnership, just what you're up to, what you've been focusing on. I think that would be useful for the committee every so often to have that as well. So there's the bigger pan health issues as well as the specific things you go into.
But they're important ones so that we have some understanding of what's being done in our name.
That's right.
And our role is to scrutinise. It's not to be presented with something saying this is a fait accompli. That's not our role.
Absolutely.
They won't like it.
Well,
and if they jump up and down, just you're the chair. You know how to deal with it. Maybe Councillor Coleman will explain it.
Well, it was interesting that Ben mentioned Merrill and Jim.
Yes, they're very good on this.
About the cooperation locally. And if you remember, we never used to get.
Colleagues, can you please speak up, because we've got colleagues remotely as well. And we're live streaming as well. So thank you very much. Okay, Jim, your hands up.
Yes, I thank you very much for calling me. I was going to say one thing, but no, I'm not. I was going to say one thing, but I'm not going to say two. One is I very much agree with what Ben has put forward. With the ICB, ICS, we're actually at the initial stages, and it seems to me that there will be a great deal of muscular work going on under the horizon before a working understanding of how democracy should work within an organisation like the ICB, covering 2.5 million people, actually evolves. And I think it's imperative that councillors who are elected get in early to make it quite clear to the ICB their voices must be heard, because the people who run the ICB are not elected by the electorates, but those of you who are councillors face an electorate and who may well have strong views on the quality or kind of health provision. But I was going to suggest one other thing, and the borough-based partnership may be an ideal way for this. Most people in the borough, most of us, our first connection with the NHS actually through primary care, through our GP service and so forth. They've changed enormously in the last several years, not least because of COVID. I think that as we look at the evolution of, for example, PCNs, the way in which we look at experience collaboration will change immensely, is already doing so. And I think it would be worthwhile, perhaps in the new year, to have the Federation and the borough-based partnership along to talk about what they see as the key issues for local provision through primary care, because it's changed and one sees lots of research nationally, and I suspect it mirrors locally. There'll be a question of access, exclusion, a question of race, a variety of questions like this, which need to be looked at in the particularity of our borough. And our doctors are key, and we need to know where they're going, what they feel about it, and what our borough residents, patients also feel about those services.
Thank you very much, Jim. Okay, are there other suggestions? I've got one as well, which is the West London Trust Care Quality Commission report.
Yeah, the CQC report. Yeah, on community-based services. Yeah,
that's something that I would like to bring to PAC, please, as well. Okay, I think we've got an interesting list there. Oh, yes, and we also have Western Eye Hospital Services.
Sorry, just surgical hubs was the JOSC point that you made earlier today.
Okay. Yes, the orthopedic surgical hubs.
Yeah, yeah. So there's a proposal that was circulated by Mick Fisher. There's a list of things that the Imperial are working on, and one of them was orthopedic surgical hubs across northwest London. Can you speak up, because I'm not sure that the people on the screen can hear. We do need microphones for these meetings.
Colleagues remotely, can you hear?
But just to reiterate, there was a conversation at JOSC this morning around orthopedic surgical hubs. Tim Orchard did a report around the work and the proposal. There was an outline business case, which was quite poor. Members were not happy about the quality of that report. It is at this stage an engagement piece, and it's looking to go to formal consultation beginning in September. So there is a discussion to be had around how that will look like. Certainly members have got concerns around the formal governance process, as well as the engagement issues, particularly around co-production and what's going on at borough level.
Are we happy with that suggestion?
As part of, if they're doing a consultation, it would make sense for them to come once they've launched a consultation.
We've invited them as well to PAC
Okay,
to scrutinize a little more about the plans. Great. Okay.
Okay.
Thank you very much.
To do a quick recap, or shall I just circulate around outside? It's getting quite late.
Did you say what? Would you like? No, we do want a summary of what we've just identified as future items for the work plan.
Yes, please.
Work program.
Okay. So we've got a, and forgive me, I will try and speak up. So we have a suggestion from Keith around autism linked to housing and mental health. Joe has commented on that and is going to look at how we can try and bring that piece together. A second suggestion was from Victoria Brignall around accessibility to hospitals by wheelchair users. And she's going to work with Health Watch on trying to bring that together for the January meeting. And Carleen, thank you very much for the offer to look at previous experiences over the past 2 years to explore what's been happening. And the third item suggested by Councillor Coleman around the Integrated Care Board. And fourth item was a report from the Borough-based partnership from Lisa as part of possibly a regular update. And finally, the last couple of items, the West London Trust, based on their poor CQC performance report, which was recently published, Western Eye Hospital and Ophthalmology Services, and finally, orthopedic surgical hubs. If it's helpful to members, what I'll do is go away and work up a long list based on that, and also referencing previous items if you would like that, and then look at trying to map that out meetings that we've got remaining for this municipal year.
Yeah. Could I interrupt there? GP services seem to have fallen out of that list.
Jim, I can tell you that that's still on the long list. As I said, there is a long list that we do circulate. Nothing's been taken off that list, and this will feed into that discussion as well.
Okay.
Thank you, Jim, for the reminder. Okay. Well, thank you so much, all. I appreciate your time and contributions and questions this evening. It's been very nice to see you this evening, and also colleagues as well joining us remotely, and officers as well with their presentations. I appreciate it. So our next meeting is Wednesday, the 16th of November.
Yes.
And before we finish, I want to thank Ashiba for all her support with this meeting. Appreciate it, and wish you all a nice summer.
We also thank you very much for providing the food this evening. Happy to have it every meeting. Thank you very much. I'd love to take credit for that, but I couldn't in good conscience do that. Please do. Both of you could.
I did. We did.
Yes.
We did.
No, thank you very much. Just put on the list for next time. I want to let you know.
Thank you.
Thank you.